This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Is there a DPC clinician, tech vendor, or industry champion that goes above and beyond to further elevate the DPC movement? Nominate them for a DPC Innovation Award to recognize them for creating traction, embracing innovation, and demonstrating commitment to the movement. DPC Innovation Award winners will be announced and honored at this year's Hint Summit, taking place in Denver, Colorado, September 27th through 28th. Nominate a DPC innovator at summit.hint.com, plus get $50 off your Hint Summit 2024 registration with promo code MyDPCStory. As we start this new year with new hopes and ambitions, I wanted to bring an interview that can impact anyone anywhere on their direct primary care or direct care journey. Whether this is your first time hearing Dr. Bliss speak or not, hearing the man who is considered by most to be the father of DPC speak about the movement is definitely something to get inspired by. Now, on to the episode. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, patients pay their doctor a low monthly membership and, in return, build a lasting relationship with their doctor and have their doctor available at their fingertips.
For me, DPC is a charmingly simple tool that changes the center of gravity in healthcare from the needs of governments, hospitals, nursing homes, pharmaceutical companies, medical professionals, and bankers to the needs of patients by building a new playing field on which patients decide what their needs are and what they find valuable. For Americans, this has the additional potential benefit of being a high-functioning marketplace with the expected outcomes of higher quality, lower price, easier access, consumer responsiveness, and easy adaptability to uncorrupted, lower-cost government subsidies for the poor and chronically ill with minimal regulations required. Think food stamps for healthcare. Insulating chronic care and routine healthcare from perhaps the worst idea in the history of healthcare, health insurance as a substitute for universal healthcare. It also accomplishes the quintuple aim: happier patients, happier doctors, lower costs, better health outcomes, and consumer-driven regulation. Not bad for something so simple. For me, DPC is the antidote for a substantial portion of the disorders of the American healthcare system and a savior for primary and chronic healthcare. I am Garrison Bliss, and this is my DPC story.
Dr. Bliss attended undergrad at Harvard College, where he studied both philosophy and biology. He then earned his MD from the University of Utah and then completed his internal medicine internship year and residency at the University of Washington. After his training, he went into private practice and never looked back. Welcome to the podcast.
Well, thank you. It is a delight to get a chance to talk to you.
You've described your journey in DPC as a transformative one. Can you share more about this transformation and how it led to thoughts on fixing something that to many seems unfixable?
This is obviously stuff that I've been thinking about for a very long time, probably over 40 years. I think that the discovery that the business model might be a problem, it took a while. to understand. And it took a longer time still for me to see how it had affected me. We're running a practice in Seattle with 3 other internists and seeing patients and charging insurance companies. I mean, insurance for the payment of everything was pretty new in 1980. And the idea that you would have a relationship with a bunch of insurance companies, that's where your money was going to come from. It took us a while to sort of figure out that insurance was an interesting way of paying for things because there seemed to be a lot of money made available. And also there was no way for them to understand what patients actually needed or wanted. And they never communicated with patients to find out whether they got what they were looking for. They just paid bills. It was like a bank that you just sent them a bill and they sent you a check. And that began to affect healthcare seriously, from my point of view, probably in the early 80s. And I began to see this in our own practices. We were just then beginning to experiment with this bizarre concept of proactivity. And we're saying, well, what if we saw people every year? What if we brought them in and we saw them and examined them and did all of our medical stuff? Threw in a chest x-ray because you'd get paid as much for the chest x-ray as you did for the whole hour of working with them. We'll do an electrocardiogram. We don't know how useful that's going to be, but we're just being thorough and that all makes sense. And pretty soon we began to act the way the entire healthcare system has started to act even then and has really taken to new heights in the ensuing 35 years, which is incredible increases in cost while everyone is thorough and while everyone documents their thoroughness. And eventually you discover that you're actually not working for people. You're working for an insurance company and you're doing what they like you to do. They want you to write a note of a certain kind. They want to have, if you want to get paid more, you do a review of systems, whether or not you need it or makes any sense. And you might do a little more lab than you used to do it a little bit. You might do an EKG on everybody who feels any chest discomfort at all. And you might want to do a chest x-ray on anybody who's a little short of breath, et cetera. All of these things begin to add up. And then when you get to the hospital level, it's crazy because there's a lot of expensive stuff they can do. You can go, that's not unusual, go to emergency and $20,000 because you have a cold and you feel a little short of breath. And it seems like a gigantic amount of money for that concept. So, I was looking at this problem of expensive care, but also not very good care, which is kind of become the hallmark of the United States of America. Not to be too negative about that. I mean, there's enormous amounts of goodwill. Doctors are working really hard. And right now in the COVID epidemic, they are taking huge risks to take care of people. But the underlying business model of healthcare is driving lots of behaviors that we do not need. So it gradually became clearer and clearer that we had to do something different as a business for 2 reasons. One of it was driving us to do all kinds of unnecessary stuff. And we began to realize that. But the other one was that our economic survival was actually going to be affected. Because as the insurance companies discovered that they were being basically pillaged and stolen from by the medical community, they decided to fight back. And the way they fought back in part was to pay primary care people less because it was harder to do. It was easier to do that than it was to tell a cardiologist they can't put in a stent, and they would get a lot less pushback when they did stuff like that. So primary care started to be this high turnover, rapid, frenzy-like care. People running up and down the halls, seeing a patient every 10 minutes, a little bit like ENT is now, ophthalmology is now. They started to hire a bunch of people to do our work so that the doctor could do more, challenging things. But the reason you needed all that was because we were busily mining insurance companies. And the thing I was longing for was a place where a person, a primary care provider, physician, nurse practitioner, physician's assistant, where someone who's doing the work of primary care would have enough time to do the part of it that I felt was the most important, which is to spend time with people, to get to know them, to develop a relationship with them that would be useful not only while they're well, but later when you really have tough stuff to treat and you need somebody you can trust to come to. So I thought that the building of that relationship was important over time. And I also felt that it would be extremely important to create a system which would support primary care through good times and bad. And direct primary care has shown its ability to do that in the toughest of times, which is the last year during COVID. This is the kind of primary care that had the least concern about survival because they worked for patients directly. They were paid by patients, and the patients weren't about to drop their primary care just because we were in a pandemic. In fact, they were just the opposite. The primary care became extremely useful because the rest of the healthcare was simply disabled. And everything was pushed into intensive care units and urgent care COVID treatment and all of those issues. But the underlying structure of healthcare was really challenged, and I think has done quite well, all things considered. But it certainly could have been better had we had a different business model. So anyway, as I was looking for a way to evolve a kind of healthcare that made better sense to me, it seemed apparent that one of the things that I needed to do was create a model that would pay you when people are sick and when they're well. And it would pay you roughly the same amount, because primary care is a kind of healthcare that has a fixed cost. Under the underlying cost is what it costs to pay the physician and the support staff, and also the facility itself. Almost no variable costs involved in this business. And if you had a certain solid cash flow on a monthly basis, you would be able to be there when they actually needed you. And particularly if it was a large enough cash flow so that you could have smaller panels, so that you could extend the amount of time you spend with people when things start getting rough. You could have excess capacity that would allow you to take care of people who are in trouble. And you could get people into the office early the next day if they were really sick. So the only question was how to do that in the simplest way possible. And a monthly fee seemed like a very sensible way to do it. Very few people don't want to practice the way a direct primary care doctor practices, with a reasonable sized panel, with enough time with every patient, with the patient as their only driver, that they don't work for anybody else. They don't have the confusion of insurance companies. They don't have the confusion of the government mandated reporting systems. They don't have all of that stuff weighing upon them. So their lives are cleaner and simpler. And also they freed up $1 at a time and money by not doing that. So everybody wants that, but a lot of people are afraid of it. And they're afraid of what people might say, or they're afraid that if everybody did it, we wouldn't have enough doctors. But if that's really true, then we don't have enough doctors because that's what it will take to have a great system. You can't give someone 30 patients a day and expect them to do something miraculous, or even something that they can enjoy or feel good about, or they'll have some, capacity to take care of unexpected things that come up. If you can do the same thing and you can do it in the fee-for-service world, fine, go for it. Maybe this isn't for you, but contemplating the ideal of optimizing primary care and making lots more of us as a consequence, making it a fun thing to do, something that makes you enough money so that you don't have to figure out what other day job you're going to take. And also to get all of that weight off of you so that you can focus on patients. That's the point. And if we can get that all across to people, and why the other elements, why are we doing a monthly fee and why is the patient paying it? Or somebody or why are we allowing other people to pay it when the patient can't afford it? And how does that disrupt the model? And is that a bad thing or a good thing? I come from a family where, people do bizarre stuff. It's just, my mother was the head of Planned Parenthood and the League of Women Voters in Salt Lake City, Utah. And my great-great-grandfather was an abolitionist. So we have permission in my family to actually try to solve problems that are not soluble. So it's fun to realize that people have been fighting for justice. We didn't invent the concept, and we didn't invent even the words. And he's one of the, he wrote a newspaper in Boston for 40 years called The Liberator, and he was almost lynched on multiple occasions. That they actually had to lock him in jail to protect him from crowds. So he was doing harder stuff than I ever tried to do. But there have been people who are crazy enough to look as if they're up to the job of fixing something that's simply unfixable, which is human nature and the awfulness of human behavior. But also, there's also the other side, which is delightful to see. And if you can draw on that, that's really the antidote for the disease. And also being cognizant of the gradual failure of primary care as a business. Those are, there are lots of forces at play for me.
After being on call for your patients for 40 years, you decided to retire from clinical practice. What drove this decision, and how have you felt about retirement?
I didn't think I would be doing as good a job of it as I got older and older at this point. So I'm happy to spend some time with my wife and to control my life a little bit more. But I'm not disengaged. You get to have what you get to have, and you get to do what you get to do. And sometimes you feel like a success, and sometimes you feel like a failure. But it's much nicer to know what road you're on than it is to have no idea, or to be just unhappy about the fact that things aren't the way they're supposed to be in some ideal universe that you don't belong to. So I much prefer to look at what there is to do, and then to say, well, I'll just start and then we'll see what happened. And a lot happened on this start. So I was delighted, and part of it is not being willing to quit.
Prior to today's interview, you had wanted to share 7 points about DPC. Our eager minds are open and waiting. Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com, or check out the link in the show notes.
Number one, this is a movement about a culture of care and service, much more than about being a business model. That is to say that the business model is not what is important here. It is the kind of care that's delivered, the kind of service that is accessible because of the business model. That kind of care and service, which is largely destroyed by our current business model, which is driving people to see 30 people a day to break even and pay their staff and make it all work. The point of the business model is not that this is the best business model. This is a very simple market design, really. That's really all it is, that has the advantages of markets in it, which is that you have a customer, right? When it comes to business models for primary care, there's probably a lot of different ways to do this, and they're all happening right now. I mean, all the ones anybody's thought of are already happening. Probably. I don't know all of them, but every time I meet somebody, they've got a different variation. And that's evidence that the point of this, which was not to create a business model that everyone had to do or they weren't real. The point of this was to say, understand the philosophy, understand the point, understand what we're trying to accomplish here, and understand what we're not trying to accomplish. And once you understand that, then go build something that works. And works in your neighborhood for the patients you take care of, and for you and for your staff and do the right thing and know what you mean by that. Number two, the success of the model requires that patients control the hiring and firing of their primary care, no matter who pays for that care in the first place. So it became clear early on that only a small percentage of people have extra income to play with in terms of hiring a monthly fee primary care doctor if they're paying for massively expensive insurance in the first place. So we had to look at figuring out a way to involve the current payers for healthcare, which are maybe insurance or government, but also our employers, and to a way to engage employers so that they can support primary care on behalf of their employees. There may be some imperfection to that, but there's debates within our movement about that issue. But if you want to engage 100% of America, or even more than 10% of America with this business model, you have to have a way to devise enough resources so that primary care is well supported and independent. So the doctors don't need to know that they work specifically for the patient, but if the patient can't fire them at the drop of a hat, then there's no accountability. And I think that that's important. We need to work at the pleasure of our patients. And that's one aspect of market systems that would drive a lot of the care that we want and the access that we want. And because these are things that patients want. These are not things that insurance companies care about. So number three is the point of the monthly fee is that it provides a consistent cash flow and allows us to do the thing that is important, which is to be available all the time. That is not me individually, but my group, so that you can call it any time of the day or night, 365 days a year. So that's why the monthly fee is useful, because we don't have to have a bunch of sick people to make this work. And we don't have to make them sick or pretend that the important thing is to maximize the number of diagnoses so that we can maximize our income. I want no kind of extra incentives to create the medical mess that is part of America right now. So this system with a reasonable, solid monthly fee creates smaller panels and stops rewarding over treatment, over diagnosis, over evaluation, and over pricing. Number four, the importance of avoiding fee-for-service incentives is to obliterate the idea that PCPs can make more money by doing or not doing something to patients. If you add fee-for-service to that, which is part of the concierge movement of the United States, then you have left the fee-for-service incentives intact, and that will definitely taint what you do and how much you do and how many gadgets you have in your office and how much extra money you make. It's another cash flow source, and it separates you from your patients, and it affects their ability to trust you in terms of what motivates you. My background in college was philosophy for the first 2 years before I went to biology so I could be pre-med. And so for me, the ethical infrastructure is the only thing that you can't compromise. And if you do compromise it, you should compromise it as minimally as possible, because anybody who knows anything real about ethics knows that there aren't just one set of rights and wrongs, and it is an order of it that everybody knows and understands and agrees with. When it comes to what's right, well, is it right that I make enough money to take care of my family? You bet. Is it right that I have a price that people can afford so they can see me? Yeah. And there may be a limit in terms of how your business has to function so that you can actually be there for people. So you can't just charge zero. It doesn't work. And in fact, if you judge, and that when you take insurance, you're taking somebody else's money, and that makes it easier in some respects for people to get access to you, but it doesn't, because you have to see so many people because of the way insurance pays you, that you actually compromise your care every day. So this is the where the rubber meets the road of medical care.
Absolutely.
When we decided to pay cardiologists 3 times what we pay primary care doctors, that was a good thing for cardiology, but it may not have been a good thing for patients, because primary care has a very, very important role to play in healthcare. It's not as sexy and cool, but it actually probably saves more lives and it prevents more need for cardiologists. What we've done by making this a commodity is to artificially affect what care looks like, because we're not all on the same project. Specialists are on their special project with their special patients. The primary care people are on their primary care project with their primary care patients. But the overarching point of all of this is not for us to practice medicine in the way it says to do it in the textbook. We're supposed to be producing healthier people. Mm-hmm. We're supposed to be producing people who are autonomous, who can take care of themselves to a large extent. We are trying to not indoctrinate people in such a way that we make more money. So it is, because it's very, this is where the discussion of incentives is so important. You can say that you don't pay attention to the incentives, but you do. It completely shapes your life, and it shapes your relationship with your patients in a real way, which is what people discover when they go on direct primary care for real.
No, I remember Neil Douglas once said to me, I was so good at coding. I was so good at it. And then I sat there thinking about how I was trying to listen to my patient, but in the back of my head, no, that's definitely a 99214. If I talk to them a little bit longer, I can go up to 99215. And how he hated that dichotomy. So
I should do a review of systems here. I could increase my money. And in my time, before there was all that subtlety about it, it was, maybe we should do a chest x-ray with every physical exam. We'd just be more thorough and we get paid twice as much.
And that strategy of slowly incentivizing medicine in the wrong way is really ingrained in patients' minds, still to this day. But aren't you going to check my UA and my chest x-ray for my annual physical? Because there's no reason.
Well, no, there's a reason not to do it. That's and the question is, do we even know that? What do we know and what are we making up? Because when you know what you're going to do, what your business looks like, it's easier to say this is all necessary. And I was very much a part of this evolution, because when I started as a resident, when I finished medical school, proactivity was an idea. We all sort of thought that being proactive was a good idea. We really should investigate that. But we were still just treating diseases. That's all we were doing. And when proactivity started to be a thing, we all assumed that all that stuff we'd been doing, we should just do it for everybody, and then that would be proactive. And we should do the labs every time we see a person for their annual exam, which we invented essentially at that point. And they look, maybe that's just x-rays, because every once in a while something shows up and it makes us look good, and it gives them a new problem to go on their problem list. And then we've prevented something. Well, no, maybe we created another problem, and now we know how much of a problem we created. And there's plenty of examples of that now. Number 5, primary care must be independent. So this is the hard one for a lot of people, to avoid being pulled back into the fee-for-service game by being owned and controlled by insurers, specialty clinics, and hospitals, which all benefit from overutilization, over-referral, etc. So the primary care was 10, 15 years ago almost entirely independent. And now it is more than half of it is owned by hospitals, specialty clinics, and other entities that make their money by having us refer within the system.
How does this model allow people to leave fee-for-service?
There are many variations. This is, we're starting this process. We are inventing this, and there may be better ideas that come along, or for different circumstances, you may want to do something different. There are people who are doing practices which start in mostly fee for service, and then they start adding a group of people who are paying for by the month, and they gradually increase the monthly fee people, and then they'll eventually, as they get a big enough practice, they will cut back on certain insurance companies until they're down to an all DPC practice. That's a way to do this with less risk. So that's the way they did it in Colorado with Nextera. When I talked to Clint, which is a long time ago now, like, I don't know, 8-10 years ago, I met with him, and in Denver. I was talking at a conference there, and that's where he was based. So he took me out to dinner, and we talked about all this stuff, and he said he was going to he'd been doing fee for service, but he really, really wanted to like make his way over to direct primary care. But he was uncomfortable with the idea of just, dropping a bunch of people so he could do it. And I said, fine, do what you want to do what feels right to you. And also, but make sure you get where you're going eventually. Make sure you've designed a practice that you can take care of lots of people and do it the way it ought to be done. And he's done that. Number 6, by competing for patient allegiance, we can use market forces to increase access, patient experience, physician satisfaction, and continuous innovation. That's, I think, really important. So once the patient can hire and fire you, then we are competing as independent physicians for their business. And what that means is for things that they want and need. And it also means that we have the possibility of doing something really beneficial for people, which is what most of us want in the first place. That's what we get that's what satisfies us. And our inability to do that is what makes us extremely unhappy, which causes what we call burnout, but which is really an enormous anger at ourselves for being willing to play in that system. Number 7, when the above design is brought to fruition, the net effect has always been happy patients, happy doctors, stable, sustainable income, modestly increased PCP income, dramatic increases in innovation, a markedly decreased overall cost of care, overdiagnosis, and overtreatment. This automatically begins the process of rebalancing the medical ecosystem to improve outcomes, control over utilization, and improve the lives of everyone in the ecosystem. So that's the other thing about this system, is that one of the things that primary care doctors get in the middle of with this system is managing the rest of healthcare, of getting their patients to doctors who provide great care, specialists, hospitals, to places where they won't get fleeced, places that aren't insurance mills, and also by acting as their advocate within those systems.
I have become a huge fan of podcasts. Ever since Sarah Koenig hosted the first season of Serial, I was hooked. Now, creating this podcast has become part of my daily life. While it is an exciting new hobby, I also see it as a privilege that I get to interview so many DPC and direct care doctors. If you are interested in starting a podcast, let me tell you a little bit about Anchor. First of all, it's free. There are creation tools that allow you to record and edit your podcast right from your phone or computer. Anchor will distribute your podcast for you so it can be heard on Spotify, Apple Podcasts, and many more. You can make money from your podcast as well with no minimum listenership. It's basically everything you need to make a podcast all in one place. Download the free Anchor app or go to anchor.fm to get started.
Can you touch on the idea that a rising tide floats all boats, and how we can come together as a community to promote those 7 points going into the future?
Well, what we're trying to do is really to correct an imbalance in healthcare that was created by a fee-for-service system, which massively valued specialty care, hospital care, surgical care, invasive care, expensive treatments and drugs, and way undervalued the less expensive and more patient-centric and more long-term care. And we have to fix that imbalance, and that will be a painful process. But but all you have to do is to create excellent primary care, and that begins to offload the rest of the healthcare system magically. And I've certainly seen that both in my own practice, but also in the scalable versions of direct primary care that I've tried to put up over the years, where we could demonstrate 20 to 40% reductions in the cost of healthcare, massive reductions in the number of surgeries required without any apparent loss to the patient, and with reduced lab costs, reduced x-ray costs, with less imaging. So better results, happier patients, much happier primary care people, and a stable ecosystem of healthcare. So we know this can happen, and the scaled versions of direct primary care are all doing the same thing and producing very similar kinds of data. That our system, our American healthcare system, is out of balance, and so I'm trying to rebalance it, but to rebalance it not by making primary care doctors slaves and handcuffing them to an oar in the slave ship. I'm trying to create a system which more people will want to do primary care. They will have an adequate, although not exorbitant income, hopefully. They will be able to take care of their families, and their kids get to go to college, and they will have plenty of time with patients so that they will have a rewarding life. And if you do that, then we can get up to the magic 50% primary care number, which is a number that was arrived at a long time ago by some wonderful research. But it's around the 50-50 kind of balance. And once that's done, then the specialty care people, so you don't have a big specialty clinic that's got primary care people seeing 30, 40 people a day, and everybody with a cough sees a pulmonary doctor, and everybody with any kind of chest discomfort sees the cardiologist, and gets a cath, and all of that stuff, which is emblematic of the American healthcare system. And at the same time, the cost of everything goes down, and we start to have the right number of primary care people, the right number of specialty care people, and we then get to start to thinking about the concept of how can we marry this whole thing together in a high functioning healthcare system, which does the right thing as close to all the time as possible. So I'm very excited about DPC as being the initial icebreaker to get us moving toward that goal.
When you mention that goal of 50% or more primary care, do you have any thoughts on how we can affect the pipeline of medical students and residents to join the movement and to promote primary care as a specialty?
Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad.
Well, I mean, there are so many things that we should be doing, but I think the way to engage medical students in primary care is, first of all, to have primary care practices that are ongoing, that they go and visit and say, boy, these are happy people. Everybody's happy. The patients love it. The doctors love it. I want to do that. That's first. The second thing is that you can't have a system in which you can earn 5 times as much money doing specialty work, or 3 times as much money doing specialty work, and then try to talk people into doing primary care because it's valuable to patients, but they're turning down a lot of money. So incentives matter, and if you get to do something cool and sexy and massively overpriced, then that you can feel bad about the fact you're not doing primary care, even though you love to kind of be in a room with patients. But at the same time, it's a practical matter. You got a family, and you want to be able to send your kids to good schools and whatever that is. You want to have a better house. Those forces are at play all the time right now in the selection of specialty. And also, there aren't as many programs in primary care as there ought to be, because there's not that much interest, and because people And also if you want to go into primary care, there's somebody in your training program who's going to say to you, oh, come on, you could do something better. You could do more than that. You're really one of our top students. What you could be an invasive cardiologist. You could do that. And the answer is, yeah, I could, but why would I? I can do something that's more meaningful, that I really enjoy, and that may have much greater impact on whether the citizens of this country are healthy or sick. So catching it after the fact is not an accomplishment. These are important issues. And it's not to say that, we need all of it, but we need to have some kind of way of normalizing this in such a way that we actually optimize the care. And we should be able to prove it when we do it. And that's what DPC has been, slaving away to do, even in its kind of underfunded phase. We've been collecting data to demonstrate what difference it makes. And it does. There's very little question, I think, about that now.
Do you think that there are any communities where DPC won't work?
No. That answer to your question is no. Right now, the limiting factor is who can afford to pay for it. That's the whole point. So right now, it was like when automobiles were invented. The first people who bought the automobiles were wealthy people, and automobiles were expensive. But over time, the Model T Ford was invented, and and Ford is still alive and well. Last time I checked, and that's the conundrum: is how do we take care of everybody? So in my practice, one of the things that we did at the beginning when we started what I think of as the first DPC practice in America, we knew there were going to be patients who couldn't afford it, who had insurance, or they were Medicare or Medicaid or something, but might not be able to afford it. So we had 10% of our practice for free and discounted care. And we had enough of it so that we could make minor adjustments in the overall pricing for the rest of the people, and it would just work. So this one simple business model, monthly fee, patient pays, I work for them, that simple business model is a way of providing the kind of care I have in mind. But it is by no means the only way of doing it. And direct primary care has already demonstrated spectacular ability to develop newer, more customized versions of direct primary care. So if you happen to have a substantial block of very poor people you take care of, and then you have a group of more well-to-do people who are also patients, that you adjust your price so that you can take care of these other people well, or for free, and make that decision. But the practical question is when are we going to get to a point where the government is willing to pay the monthly fee without handing us all the red tape and all the documentation requirements and all of the stuff that we're trying to eliminate, the fee-for-service incentive designs that we're trying to dodge right now. So are they willing to start paying for primary care? I've had discussions with a number of people in Washington, D.C. about finally getting over this hurdle so that the federal government, the state or state governments can get involved with paying some or all of the monthly fee for the poor. Then this is like food stamp. So we have grocery stores, and lots of us support grocery stores. We pay for our own groceries. But if the government wants to get engaged and help the poor, they provide food stamps, or they give them a credit card that they can use at grocery stores, and that allows them to make use of the service and the access and the wide range of availability that markets provide, but to engage the poor in such a way that it's not an embarrassment for them. They just use a different credit card. So it's a way of bringing the benefits of a well-designed market-based system and make it available for everyone. So when you say, are there groups of people who this doesn't work for? And the answer is no. Who doesn't need a working relationship with their doctor? Who doesn't need enough time? Who doesn't need access when they're sick? Who doesn't need that stuff? Everybody wants it. Everybody needs it. And what we've done is we said, we are offering that. And we're doing it at a price that, let's say 70, 80% of America can afford. And if we're doing that, then that's the opportunity for charitable institutions and for governments to kind of weigh in and help the people who can't get over that hump without making this into a government-run fee-for-service system with all of the fee-for-service incentives and the kind of weird pricing decisions and all the other stuff that's just part of our government-run system right now.
Do you see, in addition to HSAs, government paying in a different form for the type of quality that DPC offers patients?
Oh, yeah. I can see that. Now, there's some people in the movement who will scream if I start talking about this, but that's fine. What I'm saying is that if direct primary care can only take care of wealthy people, then it's not what I envisioned. And it's not what we want. It's not what it's not what our country needs. Wealthy people have always been well cared for. What we want is a system that can take care of everybody. We have to figure out how to get past the roadblocks. But yeah, I've talked with a number of people in Washington, D.C. about this issue. I'm saying, why isn't Medicare paying a monthly fee for independent primary care that's not tied to big clinics and hospitals and fee-for-service mills? Pull us out of that cauldron where we're basically making our ability to refer our value. Now we're handing them $2 to $5 million a year per doctor so that they can feed all of their expensive systems and overdo everything. We should be out of that business. We should not be compelled to support the highest priced and most invasive healthcare in the world. We should be here to support the needs of patients, and that will interface with that. And we'll be needing some of those exotic and great things, but we're going to need them. We need to send people there because they need that, not because the system needs that. And that's why they're paying us to work for them.
In terms of your practice, how did you go about identifying the people who were in that 10% who could benefit from care without having the financial burden of paying for their care while they were in your panel?
Oh, that was easy. When we did the conversion, we wrote a letter to people and we said, this is about the care. It's about having a survivable business model, but it's a very simple model. It's not expensive. At that time, it was $40 to $60 per member per month. That's what it was, depending on age. And if you can't afford that, tell us, and we will see if there's a way to get you on board. So if you want to join and you want this kind of care, then we will do our best to make it fit for you based upon what you can afford. And we'll let you decide what that is. So we're not going to want to look at your last 4 years of tax returns and decide, what our thresholds are, because what people can afford is more of a personal decision than it is a numbers-based thing. It's because it has to do with what you require for financial security. So yeah, we just made it easy. We said, if you can honestly say to us that you can't pay $60 a month for this, but you want to pay $50, fine, $50 is your price. If you can't afford anything, you are almost living on the street, great. Perfect. We'll take care of you for free and we'll just get an extra patient. So we allotted ourselves about a 10% free or discounted patients to start with, and then we take a look. But that's a luxury. You have to have people who can afford your fee in the first place. So don't come up with a fee that no one in your neighborhood can afford, because you will have a very small practice.
When you mentioned that you sent out a letter, how was the response amongst your patients in your previous practice?
This was the first time anybody had ever done this that I knew of. And when we first did it, we wrote a letter about 3 months before we were going to transition the practice. We'd actually had sold our practice to a hospital thinking that they were the business geniuses and they would somehow make us magically solvent. And the hospital discovered quite rapidly that this was not going to work for them. And so they immediately dropped us off to another clinic that was doing mostly government work. And they said, oh, your problem is you have too many expensive employees, so we'll take care of that. So they basically cut the salaries of all of our employees, and half of them left, and they didn't fix things that broke. And it was a terrible arrangement. So when we left that arrangement, we just said, let's figure out what it's going to cost us to run this clinic ourselves. And let's come up with a patient panel size that will support that at the price point that we think people can afford. And we did the math, and anybody who's thinking about how to do that math, I'm happy to talk with them. But it's pretty simple because it's a fixed cost business. Know what your costs are and know how many patients you think is an optimal panel. So I was thinking at something between 400 and 800 patients in those days, but we ended up thinking more about 800 because we were afraid to have a higher price at that point to make that work at lower patient numbers. But right now you just have to take a look at what the market is in your neighborhood, and you can help figure out what that price is. And then how big a panel. But I would say aim between 400 and 600 patients if you're going to do this. If you're going to have a complex practice, if you have a mostly young group of patients, then you can go for lower pricing and have more patients. But don't put yourself in the position of just running your own slave ship where you're enslaved by your choice of pricing. So make sure that you're charging enough so that this whole thing will work, and also so that you can have a little extra padding. So if you can take care of some of the most needy patients you have and don't feel like you're excluding them. So there are certainly ways to do that.
Did you ever increase your pricing throughout your DPC practices?
I'm a tinkerer by birth, I think. I wanted to see what worked better, and also understand what our pricing was doing or not doing for us. But over the years, as our costs went up, we needed to increase our pricing because the price of everything medical, everything that you buy for a medical office has been going up way faster than inflation. And so we made sure that we kept up with that, and also that we made sure that our income kept up with inflation for us. So every 2 or 3 years, we would have small increases in our pricing, and we'd explain that to people and why we were doing it. And we weren't doing it to make ourselves massively wealthy, but just to kind of keep us where we were. And I've made pricing decisions since then. When I moved to do a startup in direct primary care, we went for lower pricing for that system, and then the patients who stayed with me paid higher pricing for that, so I could have smaller panels. And then the ones who didn't want to pay that were moved over to this direct primary care startup, so they could get half price care basically, but also still have access not only to me but to this philosophy of care and this kind of care. So yeah, the price is not a fixed number. It's scary for doctors to think about pricing, and when you own a business, it's always, there's some things about it that make you uncomfortable. But if you don't think about price and you don't think about what patients are comfortable paying or how much value they're getting for their dollar, then you will be a victim of your lack of understanding of what they want and need and what they think is a reasonable price to pay for it. So you have to engage yourself in patients, not only in terms of their medical needs, but also their financial requirements. That's what market systems make you do. It's what keeps you from doubling your price every year until the insurance companies won't pay you anymore, which is the way the rest of the healthcare system has worked.
On a different note, throughout your time practicing DPC, did you work with health brokers, and how was that experience for you?
Well, we had no contact with brokers from the moment we switched our primary care practice, which is called Seattle Medical Associates. We flipped that to a monthly fee practice in 1997. And we actually had a number of discussions with insurance companies at that point because we didn't want their money, because we understood that we wanted to work directly for patients. That was part of the concept at that time. So we didn't want to get too engaged with insurance. And the time when I started to have contact with brokers again was when we started Q-Liance, which was the scaled version of direct primary care, because we realized that you can't grow anything in a bigger way unless you have some interface with both insurers and with brokers and with the people who decide the pricing and the people who decide what the premium costs are going to be. And so we found ourselves in that pool talking with those people. But at that time, brokers mostly saw us as dangerous because they already knew that we were capable of reducing the cost of healthcare. So if we reduce the cost of healthcare, that would reduce the cash flow going through the insurance company, which would in the end reduce the premium, because insurance companies are constrained in terms of how big a profit margin they're allowed. So if there's less money going under the bridge, they have to lower their premiums, and if they lower their premiums, they're really lowering their profit. And so the brokers mostly didn't want to have much to do with us. In fact, they were busily telling people that we just wanted to take care of wealthy, healthy people, and that all that stuff about better care, well, that was just us, making that stuff up. Well, we've entered a new era now, and to a large part, thanks to Dave Chase, who has been a guy trying to evolve healthcare from a non-medical viewpoint for almost as long as I've been trying to evolve healthcare. In fact, he and I met right after starting Q Alliance, and he wrote an article about direct primary care. It's a multi-billion-dollar bunker buster article that he wrote for Forbes magazine, and he talked about what this could do. Well, he's now formed another organization that I think is growing pretty rapidly, called Health Rosetta. And the purpose of that is to take the lessons we've learned in the last 20 years about how to make healthcare better, cheaper, more accessible, more effective, and teach that to employers, because they handle a very substantial portion of the healthcare budget, and because many of them are self-insured. So if they save money, they would be putting money on their bottom line, and they'd also be able to pay their employees more if they reduce their healthcare costs. So that's the one group of people who have a big effect on the marketplace, who actually will benefit from the stuff that direct primary care does in an obvious way. So he has been training brokers, and there now is Health Rosetta qualified and certified brokers who know not only about direct primary care as the basic foundation of any kind of care system that actually accomplishes the happy patient, happy doctor, lower cost, better outcome universe. So they are training brokers to walk away from their adverse incentive systems, which involve getting paid for delivering employers to the insurance company, but not delivering any savings to the self-insured employer. That is the world they live in. So they are literally paid by insurance companies for selling their product. And so that's an incentive that's massively adverse. And so they've gotten brokers to walk away from that, which is a very scary thing for them. If you think it's scary for you to leave insurance, just to think about that, that's been their source of their livelihood for years. But to start working with a different set of incentives. Same idea, but now applied to another segment of the healthcare system, and a very important one. And also leading to newer ideas in insurance itself that is more directed toward what patients want and need, what individuals want, need, and can afford, rather than how to maximize cash flow for an insurance company.
Thank you for sharing that. Some people don't know what the Health Rosetta is, or they hear broker and they get a little gun shy.
Well, this is a way of expanding the direct primary care universe by engaging employers who are likewise motivated to have their employees healthier, have better access to the healthcare system, and missing fewer days at work. And at the same time, the employer paying less money to get more services for everybody. That's a win-win-win-win-win-win solution. And this kind of a solution is the long-term answer to the healthcare system in America. And I'm hoping that the self-insured employer marketplace is going to be one of the earliest adopters.
If someone were not yet working with a broker and interested in talking to employers, whether they be a large-scale employer or a small-scale employer, do you have any suggestions as to how a person can start that conversation with your group, especially if they're in a micro practice?
Well, there are a number of ways that you can. I mean, there's some other parts of this ecosystem that have been growing around direct primary care. One company that has been here a long time and has really come into its own is Hint Health, initially as developing billing software for direct primary care, specifically monthly fee billing, which is a specialty unto itself. They have a great affection for this movement. And obviously, they've put all of their personal capital and hopes into this movement. And so they've done everything they can to support it. And part of that is to start giving courses in how to do the business part of the business, how to engage with employers, how to set pricing so that it makes sense for you and your community. And there are a number of other organizations that I've had the pleasure to meet with who are now trying to engage with this question of how do we put together direct primary care people with employees of companies and create a system where direct primary care, people who want to try direct primary care, they're afraid of letting go of their fee for service, but they might be willing to take 10 direct primary care patients to see what that feels like. And patients who want to shop around for the best direct primary care doctor they can find at a price point that makes sense for them knowing what their employer is willing to pay, what portion of that their employer is willing to pay. So they have a choice whether to get a more expensive direct primary care doctor or a less expensive one, and deciding how much of that difference they're willing to pay. So this maintains the structure of it as a marketplace. It also means that it puts a little pressure on direct primary care people who are starting out to start out at a lower price and gradually make their way up, depending on how big a following they get, how much their patients like the work they're doing, and what the actual valuation is of their practice as a matter of public knowledge. So there are now systems that are being developed. Hint Health and other companies are doing this, so that those of us who are a little scared of this concept, which is most any sensible primary care doctor, this all sounds kind of scary, not having to just fill out a bunch of diagnoses and wait to find out what you're going to get paid for 3 months from now by an insurance company. That seems less risky, but I will assure you it's not. But there's a lot that's known about this, and there's a lot about marketing that now is much more plausible than it was even 5 years ago. And also go to a HIT summit sometime. It's once a year usually, and they bring a bunch of people to give talks, from all kind of early to people who've never done it but are thinking about it. And they have courses available for people at all stages.
I love that they have their past conferences available for people who are learning about or who have missed the conferences,
Yes.
so they can still get that information.
It is such a different experience from any conference that I have been to, because this engages doctors with the reason that they started in medicine in the first place, which is actually great care, but great care as determined by what patients want and need, not as determined by what your textbook says. Although you need to know all of that too. But the idea that we're actually trying to fashion great care and to do it on a reasonable budget and do it in such a way that we improve the rest of the healthcare ecosystem, that is a wonderful space to just be in for a few hours.
I find it's a very well-rounded conference, and to hear the ecosystem, as you put it, of direct primary care involves so many professions, and to make sure that this movement continues, I think Hint definitely pays attention to that, and that's why they feature the speakers that they do.
The other thing that allows you to see, which most doctors do not see, because most doctors are in a healthcare system in which they think it's about them and what they need and what they want for their patients and what they think should happen, without really seeing the entire ecosystem. And the thing that this particular kind of care has seen from the beginning is we need all the help we can get. That we have had no significant support from insurance. We've had very, very little from national government. We've got passed laws in 30 states, approximately 30 now, to make this legal to do. And we've realized how many different kinds of people and who are a part of the current healthcare system who want to do better work and want to get better results. How many of those people can come across to this sort of monumental opportunity to fix healthcare itself? And it's fun. I mean, we aren't doing this ourselves. If the insurance companies aren't on board, then 90% of America. If the government's not involved, we've got a very large proportion of people who are not going to be able to participate because they don't understand what we're doing. They think it's just a business model. So we need to show them that. We need to engage with those people. They need to see it and understand it. That's what's going to move this movement forward. It's not just what doctors do. Our responsibility in this whole thing is, first of all, to be great doctors and to make use of the time and space and access that we have to show people what's possible and to create what's going to be possible when we innovate around what we do. So this is a place for us all to play. This is a sandbox. I mean, I was the first guy to play in the sandbox, but believe me, I want this sandbox to be all across the United States. And I want everybody in this country to have access to it. I love seeing people who are doing something with this and who are doing the next round of innovation, who are creating the next group of people who will take this thing on and carry this flag. It's the thing I didn't know when I started was how we would find the patients, how we would find the physicians. And what I've tried to do is to create a sturdy enough culture that and be public about it enough so that people will have some kind of touchstone as things get messier. It's like democracy, right? So we've had our democracy tested and it's survived, and that's good. But we also realized we need to do a little bit of, cinching up this and fixing that too, because it's not done yet. It's not cooked. And this isn't cooked either. It's not cooked until we have remade the culture of healthcare.
Dr. Bliss, you continue to be an inspiration. Thank you so much for being on the podcast today. If someone wanted to spend some more time discussing DPC with you, what is the best way to connect?
Give them my email address if they want to engage, which is garrisonbliss@gmail.com. And then, we'll decide whether to, where to go with it. I want to help this movement. I have gained an enormous amount of well-being and purpose from this movement. And I have had the delightful experience of working with other people to help them get the same thing. So to the extent that we can, there are people who want to play and they want to, talk to somebody to give them a little extra gumption. I'm happy to do that. And if there are people who are involved in a big project, or they need a board member or something like that, then I'm happy to talk with people about that too. I'm good at limiting my exposure at this point, and I've never felt that talking with like-minded people was a difficult or daunting problem.
Next week, look forward to hearing from Dr. Althea Tyndall-Smith of Gainesville Direct Primary Care Physicians. If you like what you heard today, please leave a review and subscribe wherever you listen to your podcast. Tell your friends too. For more information on this episode and much more, please visit mydpcstory.com. Until next week, this is Marielle Conception.